Good morning, everyone. I am Dr. Sivasubraminiyan, Assistant Professor in Radiology, Sri Lakshminarayana Institute of Medical Sciences, Puducherry. Today's topic is radiological approach to pneumonia. What is the definition of pneumonia? So, by definition, pneumonia is an infection of the pulmonary parenchyma. And historically, the pneumonia was typically classified as three types, that is, community-acquired pneumonia, hospital-acquired pneumonia, or as ventilator-associated pneumonia. This classification was important because the pathogens involved in the community-acquired pneumonia was quite different from that of hospital-acquired pneumonia. And there was a separate set of pathogens that were associated with ventilator-associated pneumonia. And recently, a fourth category has also been added by the WHO, which is the healthcare-associated pneumonia, to emphasize the cases of community-acquired pneumonia that were caused by multi-drug resistant pathogens that are typically associated with healthcare-associated pneumonia. So what is the pathophysiology of pneumonia? It is typically an alveolar proliferation of the microbe combined with the host's immune response to the microbe. Both of these contribute to the clinical and the X-ray findings in pneumonia. So let's first take a look at how there is access of the pathogen to the respiratory tract. Usually, there is a colonization of the oropharynx by the pathogen, and then from the oropharynx, it is aspirated into the respiratory tract. That is the most common route of spread. And the second common route of spread is hematogenous spread, most likely from the right heart, that is tricuspid endocarditis via the pulmonary circulation. And the third not so common cause is the contiguous extension from an infected pleural or mediastinal space. So, and then you have the host defense. When the pathogen or the microbe enters the alveolus, then you have the capillary basement membrane and the host defense mechanisms that start to operate. So so it not only in the capillary alveolar membrane, but also starting from the nares, external nostrils to the alveolar, you have a huge set of host defenses mechanisms. So the hairs and the turbinates of the nares can capture the larger inhaled particles. And the branching architecture of the tracheobronchial tree will trap the microbes on the airway lining. And then you have the mucociliary clearance and the IgA immunity and the local antibacterial factors that kill the pathogen along the respiratory tract. You also have the gag and the cough reflex that protect from the aspiration. And you also have the normal flora that adhere to the mucosal cells of the oropharynx that prevent pathogenic bacteria from binding. At the alveolar level, you have the resident alveolar macrophages that clear the pathogens. And once all this capacity is exceeded, then you have an infection and clinically pneumonia occurs. So the alveolar macrophages initiate the inflammatory response, and that triggers the clinical syndrome of pneumonia. There is alveolar capillary leak, which is an equivalent to that seen in acute respiratory distress syndrome. Although in pneumonia, this leak is localized. In acute respiratory distress syndrome, you have a generalized capillary leak of the alveolar basement membrane. So what happens? The capillary leak results in a radiographic infiltrate. So this is an important term. It is called, we describe it on the X-ray as a patchy area of radiographic infiltrate. And clinically, you can see detect rails on auscultation, and the patient will go in for a hypoxemia. This is due to alveolar filling of fluid, of the exudative fluid that hampers the exchange of oxygen across the alveolar lining. So what do you get? You eventually get hypoxemia. So the initial phase is alveolar edema with the presence of a proteinaceous exudate and bacteria. And then on pathology, you have the next phase called the red hepatization phase. So within the alveoli, you have an influx of red blood cells, that's the erythrocytes, along with the neutrophils. And bacteria are occasionally seen during this phase of hepatization. And subsequently, following that, you have the gray hepatization phase, when there are no new erythrocytes that are extravasating, and all those that are already present have been lysed and degraded. The neutrophil is the predominant cell, and the fibrin deposition is abundant, and the bacteria have disappeared. So after these phases, you have the resolution phase, where you have macrophages that reappear within the alveolar space, and the debris of the neutrophils, bacteria, and fibrin have been cleared. And the inflammatory response has also been cleared during this time. Moving on to the next slide. You have radiological patterns of pneumonia. These are also clinical patterns in pneumonia. And the most common pattern of radiological pneumonia is lobar pneumonia, where the infection is usually unifocal, that is restricted to a single lobe, and it develops in the distal air space, that is the periphery of the lobe is initially involved, and then it spreads to the rest of the segment with partial or complete segmental opacity. So this is what you see as an opacity on the radiograph. And the alveolar exudates lead to an opacity in the periphery of the lung, and the major bronchi and the branches of the bronchioles are not opacified and they don't have fluid. So this creates a negative image, and you get a typical pattern called an air bronchogram. And this sort of a lobar pneumonia is very common in bacterial pneumonias, especially in Streptococcus pneumonia. Then moving on to the next pattern, we have what is called a bronchopneumonia. And this is most likely due to gram-negative bacteria, as well as gram-positive coccus, that is Staphylococcus aureus. So this results usually in, this occurs usually from an aspiration of gastric secretions, and they are usually multifocal and centered in the distal airways, and they are scattered opacities, and they generally involve immunocompromised or very old debilitated individuals. And you also have the atypical varieties that don't fit into either a lobar or a bronchopneumonia pattern, and these are called as atypical pneumonias, typically caused by viral bronchopneumonias or viral atypical pneumonias and mycoplasma pneumonia. So they are reticular opacities and predominantly reticulonodular opacity. So these are the two patterns of atypical pneumonias that we see on the chest X-ray. Now let us go through the patterns of pneumonia and as we describe it on the X-ray. So this is a Streptococcus pneumonia, and you can see that on the plain radiograph there is a hazy opacity, and the lower border of the opacity is very well defined, and you can see that it's predominantly peripheral and moving towards the center like we described. And this is a CT thorax of the same patient at this level. So you take an axial CT of the lungs at this level and see it in the lung window, and you see a segmental opacity with a clear posterior margin, very well delineated, and a fuzzy anterior, ill-defined anterior. And this is a what we call a lobar area of non-segmental area of consolidation, and this is typical of lobar pneumonia. And you can also see the coronal image. You can see that it is almost resembling that of the frontal radiograph, where you can see the limitation by the minor fissure in its inferior aspect. It is confined to the right upper lobe of the lung. Then you have the atypical pneumonias caused by the mycoplasma pneumonia, where you have a patchy area of consolidation in the right lower lobe, and you also have hazy areas of ground glass opacities, and you can see that in the right mid and lower zones of the lung. And this is the corresponding CT thorax image showing hazy opacity in the dependent portion of the right lower lobe of lung, and here you can see the oblique fissure. Again, we have a focus of chlamydophila pneumonia in the subpleural region. I hope you can all appreciate the opacity in the periphery of the right lower zone of the lung, and you can see that the rest of the lungs appear unremarkable. So this is a alveolar pneumonia caused by chlamydophila. And the corresponding CT image shows the subpleural focus of the alveolar pneumonia with areas of thickening of the adjacent horizontal, the oblique fissure, as well as mild peribronchial thickening. You can see this is a branching of the bronchial tree, and you can see some amount of wall thickening around the bronchial tree. So this is classic of an infective pneumonia, where you have a exudate causing a subpleural focus with bronchial wall thickening. And we have to remember tuberculosis when we talk of any pneumonia. And in India, it is very, very common. And you see such massive area of heterogeneous haziness involving the entire left lung. And you can see some amount of shift of the mediastinum to the ipsilateral left side. And the right lung also shows some patchy areas of nodular opacities in the mid and lower zones in the pericardiac regions as well. So this is a corresponding CT image showing a homogeneous opacity of the left upper and lingular segments of the left lung, and you have some amount of volume loss in the left lower lobe of the lung. And you can see this is the scarred oblique fissure, and you can see multiple airspace opacities. Uh, those are reminiscent of the bronchial tree, which is dilated and fixed. So this is traction areas of traction bronchiectasis, and these are very classic features of tuberculous pneumonia. And then you have the mycoplasma pneumonia pattern. This is actually a particular pattern, that is a mycoplasma pneumonia pattern, that is a bronchocentric pattern, which is seen in predominantly in atypical pneumonias, but you also see that in opportunistic infection with HIV. So this is a mycoplasma pneumonia pattern, which is called the bronchocentric pattern. Now let's go into the X-ray. Here you could see that there is a heterogeneous area of haziness in the left mid zone, averting the left heart border, but there is left heart border is actually seen well through the opacity. And this is a corresponding CT image showing a bronchocentric pattern of nodular opacities, nodular densities in the left lower lobe of the lung and adjacent areas of bronchial wall thickening. So this is a patchy pneumonia with bronchocentric pattern. All right, a few more patterns of pneumonia. So this is called as a tree in bud pattern, but we are not able to see that very well on the plain radiograph. It is seen over here. There are multiple tiny nodules, and you can see that there is a branching of the nodules into a tree in bud pattern. You also see a well-defined nodular opacity in the right mid zone, and there is a haziness in the right pericardiac right lower zone. And there is evidence of fibrosis and cavitation in the left upper lobe. And we also have a pleural effusion, which is causing an opacity in the left mid and lower zones of the thorax. Now let's see the CT image. This is the typical tree in bud pattern, where you see the nodular opacities, which are tiny granules. And you can see it like dots, and you can see the branching pattern of the tree in bud opacities. And this is very classical of any endobronchial infection. But the most common endobronchial infection, especially in India, is post-primary tuberculosis, which is the most common cause of a tree in bud pattern. You can have it in other infections as well as in inflammation. So it means that there is an endobronchial spread of infection. The route of spread is airborne, and it is bronchial, endobronchial in nature. And now you have the chlamydia pneumonia, and this presents typically with infectious bronchiolitis. You can also see the tree in bud pattern like we discussed earlier. You can see patchy scattered areas of tree in bud opacities in the right middle lobe as well as in the lingula of the left lung. And you can also see the corresponding nodules, nodular densities, nodular opacities in the plane radiograph frontal projection as well, in the right lower zone and in the left mid zone. And this sort of a hazy, ill-spread, ill-defined, with no lobar predominance, it's a typical feature of a bronchopneumonia. And it also occurs in infectious bronchiolitis, and infectious bronchiolitis most closely resembles bronchopneumonia pattern, and this usually occurs with chlamydia pneumonia. Again, now this is very interesting. We can see that there are patchy opacities in the right upper lobe of the lung, but you're not able to see much more on the plain radiograph. And you can see that the left upper lobe and the left lower lobe appear uninvolved, and the right lower zone of the lung also appears normal. So you could say that it is, looking at the plain radiograph of the chest, you could say that there is a semblance of a lobar pneumonia. But when you see the CT, you can see that there is literally patchy areas of peripheral involvement, and they are diffusely scattered. Although it is seen within a single particular lobe, uh, you can see that it is not the typical bacterial staphylococcal pneumonia or the streptococcal pneumonia, lobar pneumonia that you usually see, where there is a peripheral area of consolidation. Instead, rather, there are ground glass densities, and they are ill-defined, and they are spread diffusely within a single particular lobe. All right. So contrast that with this, and you see that there is much more definition of ground glass density. You can still see the bronchial markings, vascular markings through the density. So that is the hallmark definition of a ground glass density. You can see the clearly see the bronchovascular markings through and through the haziness, and you can see that it is much more hazier compared to the previous one, and it is much more localized and much more well defined and confined to a particular lobe of the lung. Like the left lower lobe of the lung is predominantly involved, and you can see areas of alveolar densities which are segregated. You can classify them into two types. That is an alveolar density of the grade of a consolidation, as well as the alveolar density of the grade of a ground glass density. So this is called a mixed uh, density pattern, and this is proven to be chlamydia pneumonia. Another example of distribution, we can see that it is asymmetric and bilaterally distributed areas of alveolar opacities, and they are predominantly, the matrix is ground glass in nature. You can see very well the uh, bronchovascular markings through and through the ground glass densities, and you can see there is no lobar predominance, and you can see both the lung fields are involved. Although they are bilateral, it is asymmetric. It is right is more involved than the left side, and this is very classic of a bronchopneumonia pattern. This is very typical of a viral pneumonia, and like that we see here, H1N1. Again, a case of bronchopneumonia caused by Legionella pneumophila. You can see there is some consolidation in the left lower lobe, although you can see much more areas of patchy opacities in the rest of the lung fields also. You can see a small portion of the right middle lobe of the lung is also showing a patchy opacity there. So this is Legionella pneumophila, and you can see the bronchial markings over here. You can see the bronchial tree is undilated, although it is not filled with any fluid. Now coming on to opportunistic infections like HIV, you get based on the CD4 count of the HIV, you get various opportunistic infections, and the most common and the most easily treatable, one of the most easily treatable causes of pneumonia in HIV is the pneumocystis jirovecine pneumonia, and it has typical hallmark radiological appearances. Here you have a frontal chest radiogram showing bilateral hilar haziness. That is a key word to use. You have to describe this as bilateral perihilar or hilar areas of haziness with reticular pattern in the bilateral upper lobes of the lung and a few areas of nodular pattern in the bilateral upper lobes. So this is classic of pneumocystis jirovecine. Again, you can see the for the same patient, you can see the CT of the thorax showing homogeneous areas of haziness involving the bilateral lung peaks, predominantly around the perihilar regions and also extending to the periphery. Then you have the other atypical pneumonias that don't present as a bed-shaped or a patchy opacity, nor do they present as a bronchocentric pattern. There is no particular pattern involved, and these are called as nodular pneumonias or round pneumonias. And you can see there is a one such an example, which is a cryptococcus pneumonia. Okay, well, let's see the you see the superior border of the there is a radio opacity, and there is a superior border and the medial border, which is very well defined, and the lateral and the inferior borders are hazy. So and it is merging with that of the background pulmonary parenchyma. But on the lateral aspect, you are able to see a slight semblance of a hypo, what you call as a lucency, crescent-shaped lucency. Probably that is the lateral border of the nodular lesion, and so we would call it a nodular lesion on the in the right lower zone of the lung. And let's see the further imaging. You can see, yeah, this is a very well-defined nodule. By definition, a nodule is any rounded or oval lesion in the lung that is less than 3 centimeters in maximum dimension. That is called as a nodule. And if it exceeds 3 centimeters, then we call it a mass. And here we are able to see a well-defined nodular lesion in the right lower lobe of the lung. We are also able to see a few patchy areas of infiltrates in the rest of the right lower lobe of the lung as well. And this turns out to be a cryptococcus pneumonia. So pneumonia can, now we have seen all the airborne causes of pneumonia, and now let's see the hematogenous causes of pneumonia, how it spreads in a hematogenous fashion. And one such example is shown here. This is a septic embolus from a paratonsillar abscess. You can see a well-defined collection in the right paratonsillar region. That is the paratonsillar abscess, and you can see how it is compressing on the oropharyngeal airway. And this has a propensity for hematogenous dissemination and septic embolism. And that's what you see here. This is a septic embolus that has occurred from the paratonsillar abscess shown in the previous image. And you can see multiple peripherally arranged tiny nodules of densities that are seen diffusely scattered in the bilateral lung parenchyma. And this is very classic of a septic embolus. And the primary source of the septic embolus is that of the right paratonsillar region. And this is a very well-known viral bronchopneumonia that we have been dealing with in the past, a couple of years now. It's a COVID-19 bronchopneumonia, and these are the classic patterns of viral bronchopneumonia with typical imaging findings. All these red arrows point to the peripherally arranged areas of hazy ground glass densities and with the non-segmental pattern, and some linear bands of fibrosis are also seen just beneath the pleura. So they are called a subpleural fibrotic. So COVID bronchopneumonia has a propensity to elicit fibrotic response, and that you see as a radiological equivalent as areas of linear bands of linear densities, and we call it as linear fibrosis. This is a much more advanced case of COVID-19 bronchopneumonia with patchy ground glass densities in the bilateral lung peaks, which are diffusely scattered, and you can see the borders are ill-defined, and you can also see some bronchovascular markings through the patchy opacities, and that is the definition of a ground glass haziness. it is slightly more ground glass compared to what we saw previously. Now, having described all the types of pneumonias and the patterns of pneumonia, we need to understand a very important point in the radiological evaluation of a pneumonia, that is called as non-resolving pneumonia. Non-resolving or slowly resolving pneumonia, we define it as the presence of a persistence of clinical symptoms and signs like cough, sputum production, with or without fever of more than 100 degrees Fahrenheit, failure of resolution of the radiological features of pneumonia, that is a pneumonic patch, by 50% in 2 weeks, or completely in 4 weeks on the serial chest X-ray, that is indicated in at least 2 consecutive chest X-rays in spite of antibiotic therapy for a minimum period of 10 days. And sputum for acid-fast bacillus, that is AFB smear, has come out as negative for 2 consecutive days. So each and every descriptor in this definition of non-resolving pneumonia is very important, and you need to know this thoroughly. And in your clinical practice, or in your when you in your practice, that is what you will be seeing, on a daily basis. That is non-resolving pneumonia, and the causes of non-resolving pneumonia should be known, and you have to be very careful to follow up any patient with pneumonia for a follow-up of a chest X-ray in at 2 weeks, at 4 weeks, and if it does not resolve at 4 weeks, at 6 or 8 weeks, to diagnose and to confirm a non-resolving pneumonia. So let's see the causes of non-resolving pneumonia. They are usually the most common causes that of drug-resistant bacterial pneumonias. We have the most common methicillin-resistant and Staphylococcus aureus, which is the major cause of non-resolving pneumonia in the hospital setting. And you have other drug-resistant, multi-drug-resistant tuberculosis, and tuberculosis associated with HIV, which also poses a problem of MDR pneumonias, and that is the most common cause, followed by a bronchogenic carcinoma. So a bronchogenic carcinoma also resembles a patchy pneumonia on the radiograph. And a key point is the bronchogenic carcinoma will not resolve with any antibiotic therapy, whether it is resistant or not. There will not be a interval reduction in the extent of the size or extent of the opacity. There will either be a stable opacity or a gradually progressing opacity, and that should give a suspicion of a bronchogenic carcinoma. And tuberculosis, as we already discussed, is a major cause. And non-infective causes like non-infective inflammation, like Wegener's granulomatosis or Church-Strauss syndrome, can also presents with pulmonary opacities, can also they also can have fever, and because of the inflammation they can be febrile, but it is non-infective. So like Wegener's granulomatosis, they also can cause non-resolving pneumonia. So the take-home message from this discussion is any non-resolving pneumonia should be taken seriously, and it may be the first manifestation of a lung malignancy and should be considered early in patients with a history of smoking. And if there is a non-resolving pneumonia, the duty of the physician is to advise further evaluation by bronchoscopy with biopsy, and that will lead to an accurate diagnosis. Thank you.